Yes, so good evening everyone. I'm Dr. Kamal Jindal. I will be discussing your INICET recall of the physiology paper. So there were around 9 to 10 questions with overlaps some from biochemistry and medicine as well. Right? So the first question let us discuss: from lateral to medial, arrange the following in sarcomere. So remember, whenever we talk about the sarcomere, we can recall that there is a I bands which are present like this. We have a Z line. Let us say these are the I bands, right? And in the middle of the I band, we have the Z line. So this is my Z line. On the other side as well, we have the I bands, and we have another Z line which is in the middle of the I band, right? Now we have the thick band or the A band which is present like this. It is overlapped by the I bands, and in the middle of the A band we have the H zone or the H band, which is having only myosin and not overlapped by the actin filaments, right? So this is H, this is A, this is Z line, already I have written for you, and in the middle of the H we have the M line. So this is actually, if you ask me, this was an easy question and a straightforward question, because they are just asking you to comment as you are moving from lateral to medial. So as you are moving like this from lateral to medial, arrange the following in the correct sequence. So I think we can all understand. First I will have the Z line, then definitely the I band, which is not an option here, so Z line, then A, then H, and then M. That means this should be my answer, right? Z, A, H, and M. You can also look at this picture. As you can see, from laterally we have the Z line or the Z disc, then I have the A band, in the middle of the A we have the H, and finally the M line. Also we can look at the electron microscopic picture. How do I identify? The lighter areas are always the I bands. In the middle of the I band we have the Z line, and sarcomere is the part of the myofibril between two successive Z lines. So what are the areas? We have the Z line, then definitely the I band. Here the option I band was not given, so we have the A, then H, and finally the M line. Right? Let us look at the next question. So this question, again, some choices were ambiguous, and the exact recall the students are not able to do. Based on the following choices which I have been able to recollect from multiple sources, I can now say that which of the following is correct regarding coupling mechanism in skeletal muscle. Remember, whenever I talk about the coupling mechanism in skeletal muscle, so always remember, in the skeletal muscle, the main calcium which is playing the role is my calcium coming from the terminal systems, right? The calcium which is coming from the terminal systems. So let us say if I draw from this side, then this is my L tubule. Remember, this is my T tubule. T tubule has the receptors present like this, which are the dihydropyridine receptors, and these are the voltage sensors, right? Remember, these are not voltage gated calcium channel. That was also one of the options. These are voltage sensors. They sense the voltage change, or once the sarcolemma gets depolarized, they sense that, right? So voltage sensors. And over here inside the terminal systems, I have the calcium ions. Remember, this calcium is the only source of skeletal muscle contraction. There is no dependence on the ECF calcium here. And that is why we tell you that calcium channel blockers do not have any role in skeletal muscle contraction. So does the excess level of calcium does not play a role? Yes, that's true actually, that's true. Calcium is released from mitochondria? No, calcium is released from terminal systems, which is a sarcoendoplasmic reticulum, LTBUs. This entire structure is my LTBU. So this is correct. Calcium, voltage gated calcium channel opening is required? No. Voltage gated calcium channel is my dihydropyridine receptor in which muscle? That is in cardiac muscle. That is in cardiac muscle, right? Not in skeletal. So I will go with A and D. Let's move to question number 3. So which of the following acts via JAK-STAT pathway? Now, traditionally we always say that via the JAK-STAT there is growth hormone and prolactin. There is growth hormone and prolactin. So let us say I cannot remember that is the leptin there or is the calcitonin there. At least you can rule out. Aldosterone receptors, we have taught you in class, are cytoplasmic. Aldosterone mineralocorticoids have cytoplasmic receptors. The vasopressin and calcitonin also you know are G protein coupled receptors. Right? Vasopressin have various types, you know, V1, V2, V3. Right? V2 is cyclic AMP, collecting the vascular endothelium. V3 is again inositol triphosphate and calcium, and V1 is again inositol triphosphate and calcium. Calcitonin again G protein coupled receptor, cyclic AMP. So by ruling out, I can say that yes, leptin was the answer, right? So you could have done in the same way. Growth hormone, prolactin, right? Remember, everyone knows about them, right? Also, I'll show you one list of the hormones which we always show in class as well, also given in the the workbook as well as the concept book. So hormones using cyclic AMP as second messenger. Remember the glucagon, the important ones. Catecholamines, that was the previous year question. Calcitonin, right? Glucagon, ADHV2. So let's move at the question number 4. Which of the following stimulates the bitter taste receptor? Remember now, this is probably you could have done it correct, I think, because the amino acids, which is mainly the umami taste, as we say, and that is through the N-GLU-R4, and it is a glutamate. It is a fifth taste, as they say these days. It's separate from the sweet, salt, bitter and sour taste, right? So people call it sweet-like, but it is actually the fifth taste as it is written in Genome and Guyton both. Aldehyde, yes, it is a sweet-like taste. The hydrogen ions are, remember, sour. So the best answer here is alkaloid, which actually produces the bitter taste, right? The bitter one, alkaloid. Let's see the question number 5 now. So which of the following is incorrect? Here also, there is a lot of ambiguity. We are not able to, the students are not able to recall the exact question here, and the main confusion is between motilin and CCK. Now gastrin is from G cells, that is true. This is true, we all know that. G cells are present in antrum. Secreting from S cells in duodenum, that is also true. The confusion is some people are saying that motilin was given from M0 cells. Remember, if that was the option, M0 cells, then that motilin is from M0 cells in duodenum and jejunum. That is actually correct. But then the CCK was from I cells in the duodenum, and instead of jejunum there should have been something else, maybe pancreas, as some students have sent on the group, on our Telegram group. But now the other part of the students are telling that no, it was not M0, it was motilin from M cells. Now remember, M cells are not the M0 cells. The M0 cells are the enterochromaffin-like cells, and the M cells are the microfold cells. Microfold cells, are associated with the mucosa associated lymphoid tissue and the gastric associated, lymphoid tissue, and these are mainly present in, especially the malt, they are present in the Peyer's patches, and Peyer's patches are not in the duodenum and jejunum, right? So the mucosa associated lymphoid tissue, as we call them, if now it was written not M0 but only M, then definitely I will think that the third option was the previous one which I was just telling you, and that could have been CCK from I cells in duodenum and jejunum. So if that was the case, now I will go with the second one, right? So you would have to probably recall, we have tried our best, but there is a lot of confusion amongst the students. So if it was M, then I will go with CCK from I cells in the duodenum and jejunum is right, and then I will go with this as my answer for the exam, which is incorrect. But if it was pancreas, CCK from I cells, then and motilin from M0 was written, then remember that is correct and CCK1 becomes the answer, right? So please try to, maybe we have asked a lot of students, it got delayed by a day or so also, but people have a lot of confusion. Majority is saying that it was motilin from M cells. So then I will say if it was not M0, definitely this is incorrect. This is incorrect, or rather this is the answer, because then everything becomes correct. Suppose this is Isocyanum duodenum in jejunum, then this is the right answer. And now I will say this is also true, so only this is false, right? Which is the right answer. Then we had a question which was not very difficult. Hope you all got it right. All except show the Windkessel effect. Remember, Windkessel effect is seen in the vessels which have a lot of elastic tissue. And generally we say the aorta is very rich in elastic tissue, and as I move from aorta to the peripheral vessels, especially the smaller vessels, the smaller arteries, the elastic tissues, they reduce. So here, amongst the given choices, remember renal artery definitely is a branch of aorta. Subclavian, if some students are saying it was subclavian, also option was given, that is why I put up both. Common carotid, aorta. So amongst the following choices, the small artery would be, the smaller artery would be the radial artery, which definitely has the least chance of showing the Windkessel effect. Right? Let's move to the next question. So carbon monoxide poisoning causes which kind of hypoxia? So before I show you that picture, I will like to draw the figure here. Now again, this is a lot of students have given different kinds of pictorial representation. I will draw the graph for you. Suppose the graph was like this of the oxygen hemoglobin dissociation curve. Let us say on the y-axis it was written oxygen content, right? So oxygen content was written in milligram per deciliter, let's say, right? This oxygen content was written on the y-axis, and here the PO2 in millimeter mercury was mentioned. Now, carbon monoxide poisoning causes which hypoxia? Let us say that, this is the normal curve, and now as most of the students are pointing that the curve was given like this. Remember, in carbon monoxide poisoning, not only is the oxygen content reduced, but also the curve is left shifted. So carbon monoxide poisoning binds with 210 times more affinity, and it binds with 210 times more affinity to hemoglobin than oxygen. And you know that basically the dissolved oxygen is not what is affected here, but the saturation of the oxygen with hemoglobin is reduced, resulting in decreased oxygen content. And also carbon monoxide poisoning, the carbon monoxide inhibits the glycolysis, resulting in left shift of the oxyhemoglobin dissociation curve. So if the curve was left shifted, yes, and this question was also put up in the test and discussion for the INICT, so 100% the answer is anemic hypoxia. So carbon monoxide poisoning causes anemic hypoxia. Remember, in the, how do I distinguish between the stagnant and the histotoxic? I look at arteriovenous oxygen difference, right? What will happen in histotoxic? In histotoxic, such as cyanide poisoning, the tissues are not able to utilize the oxygen. So in the histotoxic hypoxia, the arteriovenous oxygen difference would be decreased because tissues are not able to utilize oxygen. So the venous O2 also remains high. But in the stagnant hypoxia, because of decreased blood flow to the tissues, there is large amount of extraction of the tissues, large amount of extraction of the oxygen by the tissues, resulting in increase in arteriovenous oxygen difference. Right? Also, this is one figure which we always show in the class as well. Remember, this is oxygen content on the y-axis, O2 on the x-axis. This is a normal person. Arteriovenous oxygen difference is around 5 ml per 100 ml. And now you can see we have two curves. One is of a patient having anemia whose hemoglobin oxygen content is reduced to 10 ml per 100 ml. Also, we have a carbon monoxide poisoning patient. The carbon monoxide poisoning patients also hemoglobin oxygen content is reduced, but this curve is left shifting. Although the arteriovenous oxygen content is same in both of them, but carbon monoxide poisoning is dangerous because the curve is left shifting, right? And you know, it can never be hypoxic hypoxia, because in hypoxic hypoxia the PO2 is decreased, and in anemic hypoxia the PO2 is normal, right? The PO2 is arterial PO2 is normal. This is normal, this is reduced. Let's move to the question number 8. Now this is again a lot of confusion is there, and a lot of students are giving us different choices. So initial increase in blood pressure. Remember, if the word was initial increase in blood pressure, then in Valsalva I do a forced expiration against a closed glottis. When I do a forced expiration against a closed glottis, then I increase my intrathoracic pressure initially. Now, increase in intrathoracic pressure, the main thing is I'm doing a forced expiration against a closed glottis. So I'm compressing my chest forcefully against a closed glottis, as we sometimes do in defecation and during parturition. So when during defecation we also increase the intrathoracic pressure, then immediately the increase in intrathoracic pressure, it compresses the aorta and causes a transient increase in blood pressure at that time, because aorta is compressed, so the blood pressure increases. So this should have been the answer, right? But again, there is ambiguity. If the increase in left ventricular volume, this option was also there, then remember, increase in intrathoracic pressure will cause increase in aortic pressure, and increase in intrathoracic pressure will also lead to squeezing of the blood from the thorax and the veins into the ventricle, especially into the pulmonary veins. They will constrict and they will push more blood into the left atria, leading to more in the left ventricle. So again, it depends on the choices. These are all the choices the students are giving us. The best answer should be increase in intrathoracic pressure causing increase in aortic pressure. Let's look at the Valsalva maneuver. What do we do in Valsalva is we ask the patient to do a forced expiration against a closed glottis. As you can understand, this is the start point, this is the stop point. So the subject is starting from here and stopping at this point. As soon as he starts, as you can observe, immediately this is called as my phase 1. So immediately there is an increase in blood pressure in phase 1 because the increase in intrathoracic pressure compresses aorta. Then this is my phase 2. In the phase 2, what happens is the patient is continuing, the subject is doing a continued strain. When he continues, what happens is increase in intrathoracic pressure is now being continued. So when he continues with the Valsalva, then in the presence of intrathoracic pressure in phase 2, there is decreased venous return. So because of increased intrathoracic pressure, there is decreased venous return, leading to decreased ventricular filling. So ventricular filling is decreased in the diastole. So once the ventricular filling is decreased, the blood pressure cannot increase. There is a further, when the venous return is decreased, then the blood pressure, these baroreceptors, once the ventricular filling is decreased, the baroreceptors will be stimulated. So ventricular filling is decreased and there is a continuous decrease in blood pressure, which will now stimulate the baroreceptor. These will stimulate the baroreceptors. Once they will stimulate the baroreceptors will try to increase the blood pressure by doing sympathetically mediated vasoconstriction. But the problem is that there is not proper ventricular filling, so they can't increase the blood pressure, right? All the baroreceptors are stimulated here. So the only thing which happens is, sometimes they ask about the heart rate. So in the phase 2, the BP cannot rise, but there is an increase in heart rate. Now in the phase 3, look at this one. This is phase 3. In the phase 3, if you observe carefully, in the phase 3, this is now phase 3. So in phase 3, he has released the forced compression. There is release. As soon as he releases, there is no more compression of the aorta, so BP falls. No more compression. There is fall in blood pressure. That is just a reversal of phase 1, as we say. Phase 3 is nothing but reversal of phase 1. Reversal of phase 1. And finally in the phase 4, which we call as this one, phase 4 is recovery. So recovery is the same vasoconstriction, the baroreceptors which got stimulated initially in phase 2 and were not able to increase your blood pressure, that increased continued stimulation of the baroreceptors leads to now increased continued stimulation of the baroreceptors, now causes increased vasoconstriction, and the blood pressure increases for 10 to 15 seconds and then returns to normal within 1 to 2 minutes, and then returns to normal in 1 to 2 minutes, right? So these are the various phases of the Valsalva maneuver. Definitely in phase 4, as the blood pressure is increasing, if I ask you what will happen to the heart rate, over here the heart rate will be less, right? Because increased blood pressure will now lead to decrease in heart rate. Over there, what was happening, the baroreceptors were getting stimulated. They were trying to, increase your blood pressure, but only heart rate was increasing. Here, what is happening? Now there is continuous vasoconstriction, there is huge increase in blood pressure, so this will now lead to more stimulation of the baroreceptors, leading to decrease in heart rate. They will not be able to decrease the blood pressure, but heart rate will fall. There, the decreased blood pressure was causing, I can add a word, less stimulation of the baroreceptors, right? Less stimulation of the baroreceptors. So let's move to question number 9, maximum thermogenic effect is of. Now this is actually a biochemistry question. The proteins have a thermogenic effect of around 30 to, we say 25 to 30-35%. So proteins have actually the maximum thermogenic effect. Again, it is around 30 to 35%, right? So it has the maximum thermogenic effect is of proteins. Then relaxation pressure is 0 at which lung volume, right? So remember, this question we again teach in class. At the functional residual capacity, the lung elastic recoil, which has a tendency to collapse, is equal to the thoracic elastic recoil, which has a tendency to expand. So lung is trying to collapse, thorax is trying to expand, and when these recoil are equal and opposite, at that time the volume of the lung is functional residual capacity, but the pressure, because both the recoils are equal and opposite, the pressure is 0, and that is called as relaxation pressure. That is 0, right? This functional residual capacity is also known as relaxation volume. So FRC was the right answer. Also, apart from this, there were 2 or more questions which I just mentioned. They have been discussed by the other faculties as well. There was a question of the cystic fibrosis. So cystic fibrosis question, it definitely affects the chloride channel, right? and chloride channel makes the secretions viscid and more and more thick. So chloride channel is a channel which is affected. And there was one more question which the medicine faculty has discussed, and that is about the Babinski sign. If that question was there, definitely the Babinski sign was there, because there was dorsiflexion of the big toe and fanning of the other toes, that is seen in Babinski sign positive, right? So this is all from my side. I hope you got 60 to 70% of these questions correct, because 3 questions were actually difficult in this. And if I have to say which ones were difficult, probably the Valsalva maneuver question was difficult for you people, and carbon monoxide poisoning you should have been able to get it. Wind-Kessler effect, also some students found it tough. This is now an ambiguous question, students are not able to recall properly. This is a straightforward one, and also a lot of people, they had difficulty in doing leptin. So I will say out of 10-11 questions which I have discussed, 3 to 4 were difficult, but 6 were easy, and you should have been able to get it right. So 6 to 7 if you get correct, and actually I will say it was moderate difficulty level, right? So once again, best of luck from my side. Keep on studying, don't give up, right? And remember, discipline is the best way to focus oneself. So stay disciplined. You have my number, I already gave that in the classes, in the TND. So you can get in touch with me in case you have any other issues, right? So best of luck, take care.